So I was asked to present you the alternative access TAVR. Let me share my screen. So can you see my slides?
Yeah, definitely.
So navigating the landscape of alternative access TAVI, this presentation critically evaluates patient selection, technical strategies, and outcomes in patients unsuitable for transfemoral access. These are my disclosures. The recently presented 10-year follow-up analysis of the PARTNER 2A trial provides important insights into the long-term durability and clinical performance of the first-generation balloon expandable TAVR compared with the surgical AVR in intermediate-risk patients with severe symptomatic AS. At 10 years, all-cause mortality was significantly higher in the TAVR group compared with surgery. But the critical observation from this analysis is that among patients treated through the transfemoral approach, long-term survival was comparable between TAVR and surgery. In contrast, patients undergoing intrathoracic TAVR, in other words, transapical or transaortic access, experience significantly worse outcomes. TAVR volumes have increased every year, exceeding surgical AVR in 2019. At that year, according to the STS-ACC TVT registry, which remains the largest national registry that includes all consecutive TAVR procedures performed in the United States, femoral access increased to 95.3%, while alternative non-femoral artery access was still necessary in 4.7% of TAVR procedures. According to the BIPA MedTech research that has been helping organizations in the medical devices community access key insights and analysis, the counts of transfemoral access utilization demonstrated a continuous rise between 2013 and 2025. For example, in Europe was 96% and in Germany was 94%. Conversely, the largest decrease was found for the transapical access route, with similar stable counts for the transaxillary access route and transcarotid transcaval access route, whereas the transaortic access route seems no longer to be utilized in Europe and Germany, respectively. A key question is the threshold of peripheral artery disease severity above which the transfemoral approach will be less safe than an alternative access route. The hostile registry attempted to answer this question using the hostile score, a new tool created to characterize the extension and complexity of peripheral artery disease. It is a simplified scoring system based on CTA, consisting of 7 anatomical variables. It can range from 0 up to 39 points. In patients with hostile scores less or equal of 8.5, transfemoral access was associated with lower all-cause mortality than a transthoracic approach, and the reduced incidence of cerebrovascular events compared with the non-thoracic alternative transvascular access. For more complex peripheral artery disease with a hostile score more than 8.5, a tailored approach seems more reasonable on the basis of patients' characteristics, severity of peripheral artery disease, and the center confidence, of course. The hostile registry sought to compare clinical outcomes with transfemoral access, transthoracic access, and transvascular alternative access in TAVR patients from 28 international centers. The patient had severe peripheral artery disease and hostile femoral access, and transfemoral access was either impossible or possible only after a percutaneous treatment. The primary endpoint was the propensity-adjusted risk of 30-day major adverse events, defined as the composite of all-cause mortality, stroke, or main access site-related major vascular complications. Among the 1,700 patients included in the registry, 30% of them underwent TAVI with transfemoral access after percutaneous treatment, 37.6% with transthoracic, and 32% with transvascular, mostly transaxillary approaches. And compared with the transthoracic approach, both transfemoral and transvascular access were associated with lower 30-day rates of major adverse events, driven by fewer access site-related complications. Transfemoral access compared with transvascular was associated with lower 30-day risk of stroke or TIA. Apparently, transvascular approaches appear preferable over transthoracic approaches when femoral access is unsuitable for TAVI. A recent meta-analysis compared the two TAVI approaches in 18 studies published through 2023. More than 5,000 patients treated with transvascular TAVI were compared with 6,800 patients who underwent transthoracic TAVI. The latest, the transthoracic, transapical, or transaortic, was associated with an increased risk of all-cause mortality at 30 days and 1 year, with a relative risk of 1.99 and 1.31, respectively. Furthermore, transthoracic access was associated with a higher risk of major postoperative complications at 30 days compared with transvascular TAVR. This included a higher risk of acute kidney injury requiring renal replacement, life-threatening bleedings with a relative risk of 1.71, new onset of atrial fibrillation or flutter, and those undergoing transthoracic access were also significantly more likely to be discharged to a facility other than home. For some reason, okay. So this slide represents yearly trends in alternative non-femoral access routes for transcatheter procedures broken down by device manufacturer. Once dominant transapical and transaortic access has, with the red line, has sharply declined and now accounts for less than 10% in both graphs. This reflects a clinical shift away from the more invasive access methods, barely used in 2015. Transcarotid access with the light blue line has significantly increased. Now, the most common non-femoral access for both Medtronic in panel A and the networks in panel B by 2023. Imaging evaluation of alternative access is of paramount importance. To optimize image quality and contrast and radiation dose, a two-step strategy is recommended: an ECG-gated volume scan of the aortic root and heart, followed immediately afterward by a non-ECG-gated scan of the vasculature, including the neck, thorax, abdomen, and pelvis. This can be achieved using a small amount of contrast administered once before the two combined acquisitions. The axillary artery is an attractive route due to its extrathoracic location, relative ease for surgical or percutaneous access, and is of sufficient size of TAVI delivery systems. The left axillary artery typically allows more favorable delivery angles relative to the aortic valve, and appears less tortuous and preserves the innominate artery by cerebral embolic protection if necessary. Here is a case from our institution, from our practice, a valve in a surgical valve with an Evolut FX 23mm valve. And here are the most representative observational studies of transaxillary access approaches for TAVI that included more than 5,000 moderate to high-risk patients. They reported a high procedural success rate of 97.3%, with a low major vascular complication rate of 3.8%, but a stroke rate of 6.2%. And such reports often do not classify covered stent implantation, which is a common practice in transaxillary access, as a complication. And this is we have to take into consideration. The premise of transcaval access is that in a closed retroperitoneal space, interstitial pressure exceeds venous pressure. So aortic bleeding, therefore, can safely decompress directly into the venous system through the nearby inferior vena cava hole rather than accumulate as a retroperitoneal hemorrhage. Femoral vein transcaval access offers familiar ergonomics with the transfemoral approach and reduced radiation exposure compared with the other non-femoral artery access techniques, and similar risk of iatrogenic stroke compared with the femoral artery access. The observational studies of transcaval access include only 416 patients. The success of the procedure was 98%. Major of life-threatening bleeding was 11%. And major vascular complications, including the cavern stent implantation, was 13%. The carotid artery is a convenient site for access owing to its extrathoracic location, size, proximity to skin, ease of surgical exposure, and often favorable angle to the ascending aorta. Early concerns for an increased risk of stroke are not supported by contemporary outcomes. There are several potential explanations for the similar or lower stroke rate with transcarotid access. During the procedure, clamping the distal common carotid artery and flushing potential debris before unclamping may protect the ipsilateral hemisphere of cerebrum. And in addition, transcarotid access typically avoids traversing the origin of the vertebral arteries, which is the case in transaxillary approach, and offers a direct route into the ascending aorta. The representative observational studies of transcarotid access include 2,600 patients. The stroke rate at 30 days was 3.6%, while vascular complications reported only 2.4%. Major bleeding occurred in a mean of 6.3%. The length of stay was 4.2 days. Here is a head-to-head comparison of the transvascular approaches that is based on the previously mentioned observational studies. Going back to the TVT registry, this is a propensity match analysis of the TVT registry with regards to the self-expanding valves. It included 576 patients receiving transcarotid and 1,142 patients receiving transaxillary access. Transcarotid versus transaxillary using the self-expanding valve was associated with procedural benefits and significantly lower stroke and mortality at 30 days and 1 year. An increased stroke signal was also observed at 30 days in the propensity matched STS-ACC TVT registry analysis using the SAPIEN valve, the balloon expandable valve. Although there are no randomized comparisons, the benefits of transcarotid over transaxillary access appears agnostic to the transcatheter heart valve type. So it's irrelevant with the type of the valve we're going to use. The primary benefits and drawbacks of the different vascular access sites that have already been mentioned are summarized here. Due to time constraints, I will skip this slide. While current 2020 ACC guidelines lack specific recommendations regarding alternative access techniques for TAVI, they implicitly recognize the heightened procedural complexity of non-femoral approaches. These guides mandate the alternative access cases be managed at the level 1 valve centers, the comprehensive valve centers, while restricting level 2 primary valve centers to a transfemoral only paradigm. The ESC guidelines acknowledge the need for non-femoral alternative access, but they do not provide specific detailed recommendation on which alternative route is superior. In conclusion, Mr. President, there is a growing belief and the body of evidence that keeping TAVR procedures transfemorally is the right way forward. However, operators should be adequately trained to manage complex vascular anatomies and potential vascular complications. This strategy should be considered only after a thorough risk-benefit assessment. As non-transfemoral TAVR volumes are typically low, it is primarily the expertise of the TAVR team that determines which alternative access will be the preferred choice. Given the infrequent use of non-transfemoral TAVR, properly mastering one alternative access TAVR technique is preferable to maintain the required expertise. And over the past decade, transvascular approaches such as transaxillary or transcarotid or even transcaval have mostly replaced transthoracic TAVR approaches, reflecting better clinical outcomes, lower rates of complications, and of course, less invasiveness. Thank you for your attention.
Thank you, George. Excellent talk. This is an interesting thing. So, from the old days, the cut-down era, there's still a need to have alternative access from time to time. So, it depends on the operator. Personally, we would do 2% transcarotid or transsubclavian. There are operators that are doing still a lot of cut-downs, like 30%. Maybe the answer is in between, but once you develop certain skills like a peripheral balloon angioplasty and IVL, you don't need to get to have that high frequency. So I think it's more standardized, the transfemoral procedure. Even when you are doing IVL or angioplasty, I think it's better for the patient in terms of transthoracic. So what's your take, Danny?
Unless it's very, very disease altering and you might not go. And the transcaval was presented here also during the talk. It's ergonomically much easier. And we are used to stand on the right side of the patient near the groin.
So the transcaval, but it has to be, there is a learning curve. So we were debating about that, and we were talking with Arik before. So you need to have a learning curve. You need to have the number of patients to preserve this learning curve, right? So maybe it could be, for Greece, for instance, would be 1 or 2 centers to do that, but not, very democratized. Do you do in Germany transcaval procedures?
Transcaval, we stopped doing it, to be honest. We did it a few years ago, but now the options that have already been described today are so good. So we do a lot of subclavian, and it resolves always the problem, almost always. So there is no really need. Maybe you have a Leriche syndrome with no access of subclavian also. Maybe we could reconsider it, but it's not having that meaning that it used to be due to the subclavian access that's increasing.
Yeah. So in this session, we have one live case from subclavian, right subclavian from Onassis Hospital in the next few minutes. And we also have a very interesting case from University of Miami, live in a box. That would be really interesting, I think. So I will have to leave it there. And thank you, George. See you in Cyprus or in Athens.
Thank you.
Or maybe
Thank you.
And
All the best.
Thank you. And maybe